Hello, and thank you for listening to episode 15 of Concierge Care Advisors Senior Spotlight. My name is Mary Cordova. I'm the co-founder of Concierge Care Advisors. We help seniors find housing or stay in their home with in-home care. Today, I am blessed to be with two doctors from our advisory board, Dr. Ferris and Dr. D. Moraes. Thank you for coming today.
Thank you. Happy 25.
Happy 2025. We are excited to talk about senior nutrition and health today. Going into the new year, we think it's applicable to talk about getting moving and getting seniors nutrition and health and exposing people to what they may be missing out there. So, Doctor, I would love to start with you on what that may look like. And senior nutrition is unique to other adults. So I will start with you on the importance of senior nutrition and health.
Super. Well, first of all, I think we're all, the beginning of the year, we're all making these resolutions to change. And what's the quit day? Is it the 14th or the 16th, the National Quit Day?
Is that January or February?
It's January,
It's
like
January.
16th.
Oh, so we're only talking 2 weeks into it?
Being a little controversial here, I think that in my world of medicine, the typical answer to this is I just don't have time to talk about it. I'm going to refer you to somebody else.
A nutritionist, or?
And then you refer to a nutritionist, and many times it's not a covered services, so people then stop using it.
They
So
don't go.
we go back to the staying at the same spot, and then the conversation's never brought up again because people feel that, I as a physician who they came to listen kind of rejected their
Aren't
personal
interested.
needs, or at least didn't engage.
Right.
We've screwed up nutrition royally.
Oh, yeah. Number one, we're not really taught nutrition. Number two, we're expected to know nutrition.
Right.
And then historically...
And we don't have really good data about nutrition.
Yeah. And can I be even more controversial?
Yeah.
Sure.
This is going to be a fun one.
Yeah.
Nutrition doesn't pay. Until now. Until now.
So nutrition pays when it's detrimental to your health? Is that what you mean?
Nutrition, many times nutritional services don't pay because the insurance companies don't feel they're important, or Medicare didn't feel it's
There's
important.
very strict criteria for Medicare. It's renal disease, and I can't remember what the other one is, where they will cover it. But I don't think that matters.
It's
and
the
they cover a dietitian?
No.
Not always.
But I don't think that matters. I really don't, because I don't think that's the problem.
Well, I'm being controversial.
Sure.
Well, because they're not covering preventative care is what you're saying.
Well, you take somebody who's wanting nutritional education,
right.
They may not follow it.
Right.
That's different.
Right.
But they're wanting nutritional education, and they go see who they think they should see, who should know about nutritional education, who, number one, most of the time doesn't. And number two, they don't get paid for it, so their interest
What's their investment?
Yeah, why am I going to...
Well, the expectation, I think, from a health system standpoint is that at the primary care level, or they come to see the vascular surgeon, well, can I eat better to make my claudication or atherosclerosis go away? And the answer is no, but what do I eat? And the answer, the counseling is you print out a thing on Epic or your EMR for the Mediterranean diet or the DASH diet, and you hand it to them. And that's the end of session.
Yeah.
Or he'll refer to me, and when I say he, not Dr. Ferris, right? Or another specialist will refer back to me or punt to me for me to do that, and then
and then you hand him the diet.
Then I'm kind of stuck, right? In my office for a period of time, we had a nutritionist in house.
Oh wow!
But I could because we have a concierge-based practice, right?
Right.
And it was a zero-sum gain person within my office. We made no money off of it, so all the revenue that came in really went to her. But we felt that it was a worthwhile service
investment
to have that
into your
in-house.
Patients. Absolutely.
Correct.
Yeah.
But offices can't do that.
Right. It's out-of-pocket cost.
It's an expensive asset. You can't run a business. And while we say, we should have the right to have that in our medical system. Unfortunately, if offices ran like that, they would go broke, and there would be even a bigger physician shortage.
But I don't think any of that matters because time and time again, a diet becomes of interest, and it's looked at, and it doesn't succeed, and the question is why. And I think that you have to take, at least in this country, take a big step back again and look, why are we in some ways where we are? And as my understanding, and I could be wrong, but my understanding is that, first of all, the term 3 square meals a day, first of all, it didn't come from the 10 Commandments.
Right. It's a little wrong.
It's not in any of the world's holy books. It came from a marketing program sponsored by the U.S. government in the early part of the 20th century because we realized we had a undernourishment problem, and it hasn't gone away. And now we have an overnourishment problem, which is a great problem to have because we have, for the first time since humans domesticated, we don't have to worry about calories to survive. Now, with that has come a lot of unintended consequences. And those unintended consequences we're really realizing now. And we've gotten a lot of it wrong. I mean, even beginning with the whole notion of low fat. I think, and now the term of the day is ultra processed or hyper processed or whatever processed food. At the end of the day, the basics are not how much selenium you get. It's really how many calories that you get versus what you expend. And if you're more sedentary and stressed or both, and you're consuming more, what's going to happen? You're going to kick into survival mode, and you're going to hold on to your energy. And the analogy I've used for a long time in practice is, dear patient, what do bears do in winter?
Hibernate.
They hibernate. How do they survive hibernation?
Sleep.
They put on their
weight.
energy stores. It's not fat, it's energy stores. It's adipose tissue. It's an energy repository to survive that long fast. And that's how they survive. And then they burn it off.
Right.
Our body, our metabolism doesn't know that there's a Costco down the street. Our body, all that our body knows is we're trying to survive the next famine or the saber-toothed tiger that's going to come and take us down. That's what we know physiologically. We aren't baked into our DNA that I can run down to the bulk store or jump on my smartphone and have it delivered. So I think that we're facing a paradigm that we've never had to encounter, and we're just running around like a fire drill. We don't really know what
Trying to
do,
figure it out.
and we're figuring out what all these influences are and how to intervene with some of these influences. But at the end of the day, we have to make some tough choices on how to modify our nutrition in terms of staying out of trouble, and then for the older population, what's the best nutrition? And one of the biggest problems is we talk about, for at least some, they don't recover from an injury, they don't have muscle mass, they don't have this. Well, what is muscle? It's protein.
Yeah.
Right. So I think there's a lot of things to think about. And even the standards of what's our RDA, our recommended daily allowance, that's recommended for what? For survival, to get by. When was that studied in the context of what problem? I think that's all changed. And I think that I think we're overdue for an update.
And a couple things too.
Yeah.
We don't realize food's a drug, right? We don't think about that. Because what happens when you're down and depressed?
Right.
Some people go for food, right? If you look at what happened back in the 40s, 50s, maybe 60s was probably a little late. The big introduction of what are the 4 things that they put together in foods that makes them highly addictive. It's sugar, salt, fat, and carbohydrates. I mean, that combination has been shown to be, it releases dopamine in the brain.
Right.
And dopamine is associated with pleasure centers, just like when you wake up in the morning, you take a puff of a cigarette, or, at the end of the day, you have a drink.
But we've known that for a long time. I mean, that's a bacchanalian feast. I mean, people have been painting that for a long time.
But it's what drives a lot of times.
Sure.
So you have to engage, you have to educate, and you have to try to change a habit, right? And unless you're open to breaking the cycle of what leads to either poor eating habits or bad eating habits or overeating, you'll regress and go back to the same place irrespective of what the treatment plan was, unless you can continue the treatment plan for some individuals. So that's why eating is a very, number one, complex process. And that's why we really haven't been trained in it, because it takes a long time. If you think about it, nutrition, the field of nutrition is its own thing with nutritionists.
Mm-hmm.
But it's important to continue to engage, because I, as a physician, when I talk about health, nutrition, or eating for weight gain, which are totally separate,
Yeah.
I might have the same conversation 9, 10 times, 15 times, 20 times, and sometimes it works and sometimes it doesn't.
Right, but I think
And
we're
really quickly, eating for health when you're younger and eating for weight when you're older,
Right.
is different.
Mm-hmm.
Because I can work with a person and have them eat butter and gain or lose weight, and I can also put them on the Mediterranean diet and make them gain or lose weight. And it really comes down to what Brian said earlier. It's calories.
Mm-hmm.
It's just strictly calories in, calories out, just like your car. You put more gas than what you're burning, it's going to overflow. The same thing happens.
Absolutely. And one thing, Dr. Ferris, before I let you interject with that, my husband was a patient through your system, and he was given a diet as well, because he had cardio problems. But he was so strict to that diet that it became fearful. He went from 180
Right.
to 140, and he's a big guy, and so it was like he was so fearful of putting anything bad into his system that it was like, okay, well, you're probably gonna
Right.
die.
And I think that's wrong, because now it's become religion, and
was
there's nothing wrong with
horrible.
religion at all per se, but food is many things. It's there to survive.
Mm-hmm.
It's social, right? It's personal and meaningful. It's pleasurable. It's lots of things. And to have somebody from the position of power, I've put that stent in your heart and saved you, and you should eat this,
Right.
is kind of screwed up in and of itself, as opposed to understanding its place without the guilt, but more freedom.
Right. Yes, you can
I
still
think
live.
You can live and enjoy life,
Mm-hmm.
and I don't advocate necessarily that certain cookie with the dark outside and the white stuff on the inside, but you can have one, and the end is
You can have two if it's the thin one.
fair enough.
That reminds me of my dad with light beer.
But there's a saying in some cultures is a little bit often,
Yeah.
and those same cultures happen to have really good life expectancies, and not as many of the problems. And so I don't think that there's a strict, zealous protocol or playbook. I think it's far, far simpler, where you're going to get 80%, 90% there, when you realize it's really easy to over ingest the calories, increase the energy stores. It's really hard to rev the engine, as we talked about how many cylinders you have. Well, that's your muscle mass.
Right.
To rev the engine, but a rather more moderated approach of recognizing it's really easy to overdo it in terms of caloric consumption. So what's important to you? Convenience, quality, doesn't matter. But if you mitigate it in whatever formula for you, in terms of what goes in, you're going to start to see results. And oh, by the way, it's meaningful. Now we have new tools, right? The GLP-1s are pretty powerful in terms of their impact, and we have surgery now and so on and so forth. But at the end of the day, you still need to look at your energy expenditure, or your caloric expenditure, right? Calories is a measure of energy, and that's what we use to look at at food, and now we've got a national discussion or a national stereotype over ultra processed foods. Well, ultra processed foods are great. They can help you climb to the top of Mount Everest and survive, because it's the only way you're going to get it there. But every day and that much, probably not so much.
Yeah.
Right?
Absolutely.
And so, and then how, again, we got to where we are, not off processed foods. We got off by scrounging every little bit of what we could get, and our body adapted to figuring it out how to do
use
that.
it.
Right?
Yeah.
And that's where I think we need to be.
How do social connections and emotional well-being impact eating for seniors and their habits? We talked about, going out and being social, and we promote that, but we also, talked about if you're cooking at home, we can do it healthier, those kind of things. But I think a senior...
Well, now cooking at home is considered an exercise.
Oh, yeah.
I mean, it's physically active.
And you're being social. And, in environments of assisted living, we know the number one complaint is food in senior living. So I think, making sure that it's a social event because you want people to come out and enjoy it, but also knowing that you're having healthy food and healthy options as well.
That's a good way to lose weight.
It's just having a bad cook?
Yeah.
Yeah.
Go to a nursing home.
Oh,
I'm kind of incentivizing the exercise program. See,
Prior-
we're all full circle.
Yeah,
You exercise,
yeah.
you don't go to the nursing home.
keep you out of the nursing
You don't
home.
eat bad food.
Right.
You're absolutely right, and I've eaten a lot of foods in nursing homes because when people would say this is not good, and I'd ask them, have you tried it? And the answer would be no, and then I would try it, and sometimes I was amazed that it was very nice, and sometimes it wasn't, because individuals in nursing homes, they're eating everything from a regular diet to food that's been chopped for them,
Or pureed,
to
or
food that's been pureed,
Right.
where the appetizer, the main course, and the dessert look the same. The color's different, though.
Right. It's been through an osterizer.
And they're drinking thickened water. Because
Isn't that what astronauts had to eat?
pureed food? Yeah, but theirs is cooked by like a
Dehydration.
3-star Michelin chef.
Oh, a little bit different.
It really is. It's supposed to be really good. Yeah.
Wow.
So the answer is yes to all of those, and it depends on what you're trying to achieve. Because I've asked a number of my patients, what do you think your energy requirement is just to survive, and not very many of them get it correct.
Right. Right.
They're like, oh, it's 1,500 calories or it's 2,000 calories, and I'm like, no. Unless you're an athlete, it's not that.
It's not that. Yeah.
But
It's like 1,200.
yeah, it's a very small
1,100.
amount, and there are some children, unfortunately, who have an even lower basic metabolic requirement. They're around 300 to 400 naturally, so you can see how tough it would be for a child to go to only be able to eat half of what everybody else is eating in the cafeteria.
Right.
So that leads to a number of issues with obesity and decreased activity in schools, like you mentioned earlier. But nutrition is very complicated and complex, and you have to really individualize it to the person to see what number one they're willing to do, and number two what their goals are. Because if you can't match those two, then the success rate for whether it be weight gain or weight loss or achieving nutrition or improved cardiovascular outcomes,
Right.
it's all different. It's a formula, and every formula is different.
And one of the probably prevailing themes is that it's become less of an event and more of a everything you ingest while you're on the go from thing A to thing B, whereas what you were really describing is a stop, an event. You socially engage. It's time that could be de-escalating in terms of stress. You could be physically more active. You may take some time, whether it's at home or in a restaurant. And I'm a big fan of restaurants, but it's I think across cultures, it is cherished and valued and recognized as something that's important, and it's something we've probably gotten away from.
Yeah.
In that regard.
Especially in our own home environments. Remember when we were raised, you were home at 5 o'clock or 6 o'clock at the dinner table when
Right.
Dad got home from work. and everyone was around the dinner table and dined, and
Right.
you know, that's how we
Right.
were raised.
Right.
But you also played basketball for hours before dinner, right?
Oh,
'Cause Your parents
absolutely.
would say go.
Oh yeah, you went to school, you went to practice, and
Yeah.
yeah, came home, and
It
yeah.
goes back to
Right.
the days of hunting, forage,
For
picking
the
up camp,
food.
going to the next place, right?
Right.
We ate until the food sources decreased and couldn't sustain us anymore, and then we lost weight along the path to our new village, and then we would start over. So it gets back
Are you
to
guys reading the same book my husband is, the Lewis and Clark Expedition? No, I'm just kidding.
no.
No, but there's
Talks a lot
but
about,
there,
it talks a lot about that.
but there's been
food.
more than one story in that in that regard, and
Mm-hmm.
to play the stereotypes now of, well, you've been in class, you're pent up, you're frustrated, so you go home, put on your headset, and play video games, right? If you're lucky, enough to do that. And I was reading again one of our medical blogs, an article, and then some physician commentary, and so on and so forth, and talking about trying to wrap our brains around this challenge of nutrition and access to nutrition, and some people can't access nutrition. And one physician said, no, I live in a rural part of the country without a lot of resources, but there's a strong cultural bond towards nutrition that it is an expected effort. So
Oh.
there's a lot of influences that I think are going to be unique to that individual, that individual's family, that aren't a stereotype. They should never be a stereotype. They should be, as we've talked about previously, tailored or personalized to
Yeah.
what is it for that person. And if you're on the go all the time and constantly doing blank work or whatever, and you don't have anything active to do, and then you go out to eat, well, that starts to add up into a profile.
Mm-hmm.
And I think there's lots of profiles out there that, again, will boil down to the same principle of your body's in survival mode. It's going to hold on to every energy source. And if we've now made, through processing, energy easier to absorb, there are consequences to that. And helping get out that basic set of principles broadly to the public, broadly making it a kind of a social consciousness, is going to be much more impactful for them to decide what's important and how does that integrate into their world.
Wonderful, wonderful. I think those are great takeaways by both of you doctors. Thank you so much for your time today. And thank you for listening to Senior Spotlight number 15. And we will be definitely moving on with 2025 and continuing with our Senior Spotlight. Thank you for joining us today. And thank you, doctors. Thank you.